Hi everyone, I'm Dr. Faisel Sayed,
And I'm Dr. Dan McCarter.
and you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege. Today, we're talking to Dr. Rob Schreiber from myPlace Health about transforming care for patients and providers. Let's dive right in. Dr. Dan, it's good to see you.
Yeah, it's great being with you. Great being with you, Rob.
Thank you for having me today.
Yeah, welcome, Dr. Schreiber. You know, we love meeting physician leaders from across the country. I mean, you have more than 30 years experience in geriatric medicine. And, you know, we love to start off with our physician leaders, especially, is like the story before you became Dr. Schreiber. What was it about geriatrics and medicine? Let's go even further. What made you pursue medicine in the first place?
That's a really great question. And, as I think back, I haven't been asked that question in quite a while. I would say it was probably my experiences with my grandparents and with a lot of their friends and sort of the challenges that they had. And, I had very fond memories of some of my grandparents, and some of them had serious mental illness and the challenges that they had, and oftentimes how often they were left isolated,
Yeah.
misunderstood, and they really didn't have options. So that sort of sensitized me to older adults and caring for older adults. But when I graduated from medical school and went through internal medicine residency, geriatrics was just an added qualification. It was not a formal specialty. And I sort of fell into it because there was a need for a physician in a geriatric, which actually was like a federally qualified health center for geriatrics. And I had some time available, and I said, this would probably be interesting. And they were the most complex but delightful group of individuals I had dealt with. And one thing led to another, and that's how I ended up into it.
Boy, you know, the story about your grandparents really and their struggles that they were needing to overcome, kind of pushing you in that direction. We see that a lot. You know, these days we're reading that more often than not, regardless of how a physician may appear in America, you can assume that many physicians are experiencing some degree of burnout. They've gotten disconnected with why they got into medicine in the first place, especially in the billing model, in the RVU generating system. And so we ask this question to our physicians and the physician leaders we meet to help those who are listening kind of remember why we got into medicine in the first place. You know, none of us got into medicine to become the detailed, diligent documenters, charting a couple hours every night. It's stories like this. You know, there's something that moved you and it kind of directed you in your life tangent. I read online, and one of the points I would like to get across, especially for our students and the residents, is to talk a little bit about the PACE program.
Mm-hmm.
But there was something that you had put out on LinkedIn that about the legacy of COVID-19 that really struck with me, and you said that the legacy of COVID-19 will be to push our health system toward value-based care that emulates what PACE programs have shown can be done. So for those students and residents who aren't aware of the PACE program, would you mind explaining the program and the work that you did in Massachusetts there?
Sure. So PACE stands for Program for All-Inclusive Care for the Elderly. And it is a program that is federally funded, but it requires a state partner. So the state, the federal government, and the provider organization come together. And it's specifically for older populations, 55 and older, are nursing home eligible, that really want to stay in the community. So if PACE programs did not exist, most of the individuals we care for would be living in nursing homes. And it's total cost of care. So you get the Medicare dollar, you get the Medicaid dollar, and they're combined. And you have to basically provide all care that's required for Medicare and Medicaid with that capitated payment. The problem is that most of these individuals are dual eligibles. 50% of them have cognitive impairment and or dementia. 60% on average have serious mental illness, and most of them have lived with trauma, have been discriminated against, and may have other issues, substance use, other types of uh, challenges that oftentimes are very difficult for the health system. They also have significant social determinants of health issues as well. And so managing this population requires a integrated approach. And what's different about PACE from almost any other system, hospice has an interdisciplinary team, but there's a regulated approach to this that's mandated since 1997, I think is when, or 1996, when the original final rule came out, that states there has to be 11 disciplines, 11 people on an interdisciplinary team that makes the decisions for the care delivery of each and every individual. So that's what's different. And it's incredibly challenging because everyone on the interdisciplinary team has an equal voice. And you need all those team members to actually sort of come to a consensus in terms of care decisions. So it's if you haven't had a chance to sit on an interdisciplinary team, I would strongly recommend anybody in the audience, if they have a PACE program near them, to see if they can go in, because it's unlike anything people, in medicine have been experiencing.
We talk. Thank you so much for explaining the PACE program. We speak a lot about taking the full responsibility of care, or total risk, or total cost of care in the full risk value-based care model. And our patients exist in the same neighborhoods as the federally qualified health centers. You started your career at an FQHC. I did too. Prior to joining ChenMed, I started at a large FQHC. And it was there that I really saw how all these social issues impact the health outcomes so much more than the medications and the treatments. Our average patient at our FQHC wasn't even 40 years old. And so my friends in private practice would say, well, you're dealing with such a young patient population. They're not medically complex. And I said, well, what they may lack in medical complexity, they definitely make up for with all the social issues going on in their lives. And so when you're looking after, you were in charge of the PACE program in Massachusetts, and so now you have over 1,000 patients, and you're trying to keep them well enough and independent enough so they don't end up going to the hospital. You have this entire team of people, but what could you describe a little bit about the clinical team? Like, are you working with physicians only? Do you have a mix of physicians and nurse practitioners? If you can describe a little bit about the clinical decision making in a program like that.
Yeah, that's a great question. So a lot of it comes down to, the clinical team, the core team, depending on, most PACE programs are structured like this, but it can vary somewhat. So you will have a provider, a primary care provider. It could either be a physician, or it could be a nurse practitioner or a physician assistant. In addition, depending on the program, there's usually a nurse that sort of knows that individual the best. There also could be a home care nurse at both RNs that are involved in the care. There's also a social worker oftentimes attached to that team. Okay. So you're talking about, as a team, nursing, social work provider, and then depending on the functional needs, oftentimes as the core team, you would have a therapist, either a physical therapist or a behavioral therapist. And in addition, one of the things, as we know, mental health needs to be integrated in care delivery. So we do have mental health counselors, certified counselors and or practitioners that can also float into the team, specifically if it's an individual who has serious mental illness and that needs to be addressed. So that's the team. So depending on when we tag team during COVID, you brought up COVID, and one of the challenges was, We had many people, they couldn't get in, but we were able to reverse quickly from a center-based model where, PACE, a lot of its adult day health, actually going into the home. But it wasn't just the providers. We'd have the nurses, we would have health aides, home aides. That's part of the team too, but not necessarily the clinical team, but part of the care delivery team. And so we were able to go into people's homes almost every day of the week if needed, depending on what their issues were, to make not only certain that they were not socially isolated, but their issues and challenges could be addressed.